Is it clear now?
We can start now.
A very good evening, distinguished guests, ladies and gentlemen. Welcome to the MMA Public Health Ask and Answered Series 2, year 2023, organized by MMA Public Health Society. I'm Kuga, moderator for the event. On behalf of MMA Public Health Society, gives me a great pleasure to bid you a warm welcome to MMA Public Health Ask and Answered Series 2, year 2023. And also would like to express our sincere thanks to everyone for taking your time off to be here today. Last webinar, which was conducted in March, entitled Mental Health Among Junior Doctors, was a great hit and had received very good feedback from the audience. Today's webinar's theme is going to be on understanding national health financing from the perspective of Malaysia and Bangladesh. Before we commence the conference, I would like to share some important admin announcement. We'll be allocating some time for Q&A session after each topic where you may post your questions in Q&A box throughout this session. All doctors who participate for the 2.5 hours webinar should be eligible for 2 CPD points. Kindly note that you're required to scan a QR code using your MMA mobile app at the end of today's session. In the event that you experience issues with QR code or do not have the MMA mobile application, you may email to MMA IT support team at itsupport@mma.org.my. Without any further ado, let me start with the introduction on financial literacy. Right. So before going to the macroeconomic, let's concentrate on the microeconomic, on the personal individual self. So what is financial literacy? So in contents of the slide is going to be first introduction of financial literacy myself, followed by health financing Bangladesh by Prof. Harun, and health financing Malaysia by Dr. Muhammad Anis. So let's see what is financial literacy. As you can see, financial literacy is basically planning for the financial future, helps people in many ways, including improving their ability to, number one, setting goals, spending within their means of budgeting, preparing for emergencies, borrowing wisely, managing taxes, investing appropriately, managing risk, funding educational needs, accumulating funds for major purchases, providing for comfortable retirement, property estate planning, and supporting charitable causes. Ultimately, it all reveals the reality, imposes discipline, and exposes people to potentially helpful strategies to reach their life objective. So how is it done? So basically what we have been taught is 50% for the need, 20% on the saving, and 30% on the wants. So how is it can be done? It's based on, first, number one, we need to concentrate on need or necessary. We must evaluate our budget and the expenses, whether is it required to be a need or it's a necessary. Number two, minimize the debt expenses. For example, commodities like credit card, personal loans. Number three, find ways to earn extra cash, or in other words, it's called hustle income. As we know, they do have active income, passive income, and hustle income. Number four would be set up auto debit from your account, sending instructions. As we said, 20% savings, whereas it goes from your saving account, emergency fund, and also for your retirement account as well. I would suggest, why not you watch Get Smart with Money and How to Get Rich in Netflix for your better understanding on financial literacy. So for example, let's look at property management. In case of, let's say for your first home, would you like to buy or building? Let's say buying. A quicker, more choice on location will save on rent, but could be expensive with the existing defects after getting your vacant position, and also stamp duty and MRTA all implies. However, building, personalized and relatively cheaper, and you save on stamp duty, but it takes a longer, frustrating waits. For example, in terms of land registration, dealing with the builders, pay rent in the meantime and interest for the loan. And due diligence when buying a house, you also must consider on comparable sales analysis, professional building, and sometimes past inspection, any potential development in the vicinity which could impact your property, getting your contract looked for by a legal professional, either a lawyer or conveyancer, vendor disclosure list, covenant on the land and easements. So let's check how can we save up for a house deposit. How much deposit do I need? Normally 10% of the purchase price, the stamp duty or MRTA or MLTA. Should I go for a lower deposit? Can, but it depends and it is complicated. So how do I save that much of money? Yes, first of all, we must have a clear goal. We must have more earnings than the spendings. We must evaluate our need and necessaries. We must also have a good personal finance strategy. Also get rid of consumer debts. For example, I said credit card, personal loans, and avoid lifestyle inflation. Have some extra income sources, the hustle incomes and passive incomes. As we know, the typical loan of housing can typically goes to 30 to 35 years. And there are multiple strategies you can use to pay off your mortgages earlier. Another options will be investing. So for example, property, or also in shares or bonds. Other alternative assets, for example, in insurance, commodities, for example, gold bar, and speculative assets like crypto. There are many more options and many more ideas on financial literacy where you can get the knowledge from. So these are the references I've gone through and come up to the slides. So as we can see, there are many ways we can learn on financial literacy. How about when we managers in a health, in a bigger picture, a macroeconomic point, how we're going to manage that? So let's hear from the experts from Bangladesh. Before that, let me introduce the introduction to Prof. Harun first. So Prof, allow me to introduce our first speaker of the noon today, which is Professor Dr. Harun Rashid, who is a former professor and chairman of the Department of Accounting and Information Systems at the University of Dhaka. During his long teaching career, he served as a vice chancellor at the Presidency University, a professor of accounting at Inti International University, Malaysia, and adjunct faculty of University of Nottingham at its Malaysia campus. He'll be presenting on health financing Bangladesh today. So please wait, haven't finished yet. Please just bear with me. So Professor Rashid was the founder, president of Dhaka University Accounting Alumni, and is serving as the chairman of its President's Forum. He was also the founder president of Information System Audit and Control Association of Dhaka chapter. He is the founder president of Bangladesh Accounting Association. In this professional arena, he was a senior consultant at Economic Relations Division of the Ministry of Finance for more than 1.5 decades and also has more than 1.5 decade, and also has a good number of research studies on public financial management in the area of health, nutrition, and population sector program, including national aid policy and LDC graduation project. He has participated in many international conferences and consultative body meetings on public financial management, including the 4th High-Level Forum on Aid Effectiveness in 2011 in Busan, Korea, and 2nd Consultative Summit on Mutual Accountability in 2016 in Paris, France. Professor Rashid provides advisory services on project oversight management to UNDP, County Office Dhaka for about 2 decades. Prof. Rashid is also the founder of Doctorby, an integrated digital healthcare platform catering the mobile-enabled connectivity between healthcare seekers and healthcare providers, with the facilities for health data capture, store, and maintenance for the record-based consultation and treatment. All right, so I'm passing the floor to Prof. Harun to commence your speech. The platform all yours, Prof. Harun.
Thank you, Dr. Gogan. Hello. Hello.
Yes, Doctor, we can hear you.
Yes. Thank you, Dr. Gogunishan Krishnamurthy, and a very good evening to all of you. I'm really delighted to be here with you for the exposure of my experience in the healthcare systems in Bangladesh, and to get through you how it works in Bangladesh with respect to the healthcare systems, which is you'll find very different from that of Malaysia. As you know, Bangladesh is one of the growing lower middle income country, and where actually the demography is like this. Total population of the country is 169 million. Density of population is, which is very different from Malaysia, is 1,169 person per square kilometer. Population by age is within the age group of 0 to 14, it represents 26.8%. Population age group represents 68% for the 15 to 68 years. And above that, 65 years plus is 5.2%. Population by gender is almost 50-50. Male is 50.53% and female 49.47%. GDP per capita is much lower than Malaysia as compared to Malaysia, which is around, at this moment, is $2,687. Interestingly, with this, we are also maintaining a very strong policy paradigm for our national health, which is also very different from Malaysia. Our national health policy actually was formulated in 2000, which is 29 years after Bangladesh's independence from Pakistan. So it took 29 years for the citizen, for the country to have a national health policy. But with that, the journey started with a concrete policy for the development of healthcare systems for the citizenry. So citizens' constitutional right to receive healthcare for the first time through this policy statement of the government, which is known as National Health Policy. And in that policy, the government pledged to ensure delivery of health and nutrition for the entire population in the most effective manner. That is the policy statement pronounced at that point of time, 23 years back. Subsequently, by the year 2021, and in the middle of the MDG regime, Millennium Development Goal regime, the government felt to revise this national health policy, and more of the MDG focus has been brought in the revised health policy, and universal healthcare has been brought into the center of the entire nation's healthcare management. So in that, this revision has brought into picture the concrete goals and objectives, numbering 19. Policy and principles has been articulated within this framework of revised national health policy. 16 policy and principles were identified, and very strong 39 strategies has been identified for the implementation of the newly defined MDG focus and universal healthcare centric goals. So it has been brought into a new regime of healthcare financing strategy. So the redefined healthcare delivery system has been brought into the picture. Healthcare financing and expenditure for the universal health coverage has been seriously considered, and milestone has been set for the implementation of the universal health coverage mandate of the international community. So the most important phenomenon at that point of time, 12 years back, it was the community-based healthcare system has been introduced with the pronouncement of the beginning of 13,000 community clinics at the grassroots level, at the village-centric community systems. So with that, actually, by the year 2015, when the MDG is closing and is transforming into SDGs, Sustainable Development Goals, Bangladesh has been very successfully achieved couple of very important milestones of the MDGs, which is child mortality reduction. And at that point of time, infant and under 5 death rates has been reduced from 144 per thousand live births to 41 only. Almost 1/4 of these things has been achieved during these couple of years after the introduction of the revised national health policy. Now it is actually at the level of 21.56, as you can see. There has been significant improvement in the reduction of maternal mortality, and it is at that point of time was identified at a level of 66% reduction from the year 2000. From 372 deaths per 100,000 live births to it has been reduced to 245 by the year 2015. And with that, a new target for the SDG has been set by the government within this national strategy, financing strategy to 70 to achieve by the year 2030. Reduction in fertility rate was also identified a critical issue for the implementation of the policy paradigm in the healthcare management. 2.32 births was prevailing at that point of time in 2010 per woman, which has been reduced to 1.93 births by the year 2022. And SDG target has been set at 1.7 birth per woman to be achieved by the year 2030. So that is the beginning of the National Healthcare Financing Strategy, and which is being adopted by the government at that point of time. With the fag end of the MDG regime in 2020, a 20-year strategy has been set, which is the main subject of the discussions today, healthcare financing in Bangladesh. So with this financial strategy, the objectives has been very clearly identified: ensure solidarity in financing for national healthcare, enhanced annual budgetary allocation for total healthcare expenditure, THE. It was at that point of time, total healthcare expenditure was 4.6% of the total budgetary expenditure, total budget of the government. So it was 4.6% in the year 2012 and 13. And it has been brought, the target was to bring it down to take it to 15% to meet the WHO standard. So the budgetary allocation at that point of time when the strategy was being formulated, it was 4.6% of the total national budget, but the target was to meet the WHO standard at the level of 15% of the total national budget for the healthcare. Unfortunately, the government could not achieve 1/3 of it. It could move from 4.6% in 2012-13 to 5.05%, a slight increase by the year 2021. So this is one of the very weak area of the Bangladesh government's national healthcare financing strategy. The other thing was that at that point of time, there has been a mandate from the from WHO, World Health Organization, to take the total healthcare expenditure to 5% of the GDP. But unfortunately, in this respect also, the government has failed to take it to that level. By the year 2021, it has been able to reach up to only 20% of the target. By the year when it was in 20.69% in 2014, 14, 15. Still, after 6 years, by the year 2021, it has still been less than 1%. So this is one of the very critical area for the government to achieve and to move forward, to take it, to speed up the allocation for the total healthcare expenditure. So to give a snapshot of these things, in Bangladesh, government spending actually represents only, at this point in time, 26% of the total healthcare expenditure, and 68% of the total healthcare expenditure comes from the people's money, meaning out-of-pocket cost. And social health protection, mostly designed by insurance. So Bangladesh is really lacking much behind the world standard. So it only represents less than 1% of the healthcare cost is covered by insurance. And other development partners and NGOs provide around 9% at the moment. But in the financing strategy, the projection was, the government spending shall move to 30%. Out-of-pocket expenses, out-of-pocket cost has to be curtailed around 32%, which is now more than double. And the social health protection, meaning that insurance coverage for the healthcare systems, has to be 32%, which is at the moment only 1%. And others contribution in the healthcare management has to be 6%, which is a little more in that respect. So if we look at the strategy was very ambitious, but in terms of the implementation of this healthcare financing strategy, it is still lagging much behind in terms of its management. And for many different reasons, it is still in the incubation. I must say that there has to be some very aggressive move from the government in the management of the healthcare, national healthcare, as well as national healthcare financing. So the serious enhancement is necessary in the efficiency of the resource allocation and their utilization. But the government still is in the process of thinking about bringing it down to 50% of the current state to 32%, which is still the government believes that it is possible to achieve. So this healthcare spending status is really very a poor picture of the country's healthcare management, healthcare spending. This poor funding of the national budget, which is around 5.05%, WHO proposal is 15%, inadequate infrastructure and logistics. Per 10,000 people, hospital bed is only 8 hospital bed is available for 10,000 people. Inadequate manpower, per 10,000 people, number of physicians 3, and number of nurse and midwives are 5, something like that. So this is the real core causes of the healthcare system sufferings. And this is relatively comes from the poor funding. Government healthcare expenditure is hovering around 5% of the total public spending. More than 7/10, around 68% of the healthcare cost is covered by out-of-pocket costs by the citizens. And from that out-of-pocket cost, 61% of the cost is account for buying drugs, medicine, lab tests, and doctor's consultation. And that actually causes low per capita share of public healthcare expenditure. And per capita healthcare expenditure is around $54. WHO standard is $120. 36, which is around 5% of the total GDP. But it was in the ambitious national health policy, revised national health policy, and the national healthcare financing strategy back in early 2012-13. It was proposed that the government per capita spending was 23, but it has moved to 54, more than double by the year 2021. So what is the impact of this low per capita health spending? Impact on health care services, overcrowding in government healthcare facilities, poor service, inadequate attention, delayed response, and involving personal costs. Huge out-of-pocket cost, which is around 68% at the moment, but government is committed to bring it down to, projected to bring it down to 32% by the year 2030. Only 5 years left, only 7 years left. But during this period, it is still in the escalation side, not declining. It is still escalating. Crowding to public facilities, which actually caused mushroom growth of private facilities, hospital, clinics, private chambers with very meager, inadequate facilities. More dependency on private chambers. Most of the government doctors do their chambers, private chambers in their private chambers, spend their time, and that is one of the really precarious scenario in the healthcare systems. The doctors in the government hospitals, they actually spend less time in their work site. They spend more time in their private chambers. And increased burden on OPP. The OPP, it is supposed to be, when it was planned, the financing strategy was planned in 2012. It was supposed to come down gradually to 32% from 64%, but it is still in the upward, it is maintaining upward trend. It is touching 70% of still in the escalation stage. So overall impact of these poor funding and poor healthcare services is lack of suffering of wellness, and well-being is threatened. Surprisingly, it is found that about 16% of the households face financial catastrophes each year, which actually causes that the people avoid going to the hospitals. They cannot afford to go to hospitals, so they suffer from non-medical services during their illness, and that impacts their wellness and well-being. 16% of the households remains outside the healthcare facilities. And that actually causes inadequate consumption of food and other services. In most of the cases, asset depletion. Those who can afford to go to the hospitals or for medical attention, for the medical treatment, they need to sell their house. They need to take loan from relatives or the NGOs and other things. So that causes a serious depletion in their assets. And children drop out from education. They compromise their health care and at the cost of their children's education. In that cause more child labor in the market, and finally malnutrition population. So these are some of the statistics where we can see that when the national health policy was formulated, the per capita healthcare costs spending from the government was $9. So it now moved to $46 to $54 by the year in more than 2 decades time. And out of that, per capita health is still very poor, and there is you can see a comparison of Bangladesh healthcare system, health spending with other Asian countries. Singapore is at the top, where Singapore is spending $2,632.71. Bangladesh is spending like $45 or $46 at this point in time. And Malaysia is spending $436.61. This is taken from the net. I'm not sure whether it corroborates with the actual figure, but it gives the glimpse of the very precarious situation of the wide variation of the healthcare spending in different Asian regions, where Indonesia is spending around $120, and Cambodia $113, and Myanmar $60, and Bangladesh is at the lowest level, $46, $47, like that. If we look at the budgetary allocation in Bangladesh in terms of these percentage, as I mentioned, from 2010 to 2009-10 budgetary year to 2019-20, it has been scored here. So it started with 6.2% of the national allocation, national budget, but it hovered around 5% like that over all these years during the last 12 to 13 years. And healthcare spending, the historical side, as I mentioned, it is from starting from 9, it has gone to that level. So in terms of GDP, if we look at this, the same picture is available here. So budgetary allocation for Bangladesh, it started with, if you look at for the 5 years, 14, 15, it was around 0.69 in terms of the GDP in comparison with GDP. Now it has moved to 0.92%, but the government's commitment is to reach at the level of 5% of the total GDP for the country. This is again the synergy of a couple of Asian countries, where Bangladesh is at the level, at the lowest level, and in the range of Pakistan. Now, having said this, the most important part of this, where do we move? Looking back, during the last 20 years of Bangladesh experience with healthcare financing, it has been clearly visible now that Bangladesh will never be able, with this speed, with this policy, to achieve the goals of the Sustainable Development Goals, or the objectives of the universal health coverage. So what is waiting for the Bangladeshi to achieve? So that is where the dimension is now opening. The digital healthcare is one of the quickest possible and achievable solution in terms of the in comparison with other many advanced countries. So digital healthcare is one of the most achievable achievable dimension, which can actually create a synergy for the people to get involved, to get attached with the entire healthcare systems. So taking the advantage of the fragmented healthcare systems in a country where the doctors, patients, hospitals, government hospitals, private hospitals, all are fragmented in many different directions. It can be brought into one synergy if we take the step, we pursue the policy of digital healthcare transformation. So the fragmented healthcare systems can be actually structured around digital platform, wherein the good solutions can be attained by educating the people to be connected, to remain connected with the healthcare systems across the country in terms of the physicians, connectivity with the physicians, in terms of the connectivity with the healthcare service providers, healthcare facilities through their mobile-based healthcare systems. And that actually allows the individuals to store their health records. I mean, electronic health records in the platform, wherein this platform can store as many health records as possible in continuity, stored in the cloud, shareable platform, wherein each individual can remain 24/7 connected using the mobile technology with their chosen hospitals, with their chosen platform, with their physicians, wherein the distance doesn't matter, money doesn't matter. The platform allows the individuals to remain 24/7 connected. That allows the individuals to remain, to get educated with the causes of with the causes of their healthcare management systems. You see, the most important problem of the fragmented healthcare system is people avoid their illness or sickness in the first place. And in Bangladesh, everybody is doctor in the sense that they go for the self-medication first, and in the next stage, they go to the pharmacy to buy medicine at their own prescription or with the suggestions of the dispensing person. And finally, when the disease is incubated into a bigger issue, then they move to the doctors. Instead of doing so, the people can be educated by using their systems, digital healthcare systems. They will be interested, they can store they can be connected in the first instances of their sickness, in these first instances of their illness, and they can have consultation with the doctors. These doctors can issue prescriptions and they will go to the pharmacy, or even medicine delivery systems from the pharmacy can be arranged within the system so that the doctor can actually send the prescriptions to their chosen pharmacy or dispensing stations. So the whole structure will be systematically arranged in such a manner that a digital healthcare infrastructure grows around the philosophy of engaging citizens in the management of their healthcare systems, and unnecessary tests can be avoided, costs on buying medicine can be avoided, and unnecessary cost of dispensing can be avoided. So that actually reduces the burden of expenses on the part of the individuals, and the individuals who actually take the policy of getting connected at the very first moment of the symptom of sickness or wellness, sickness or illness, they will be interested to get connected with the system, with the doctors or physicians, and they get support from them. That saves money on their part, that saves money on the national budget, that saves money in every cases. And with that, actually, the whole system can be structured around the financing system so that insurance can be incubated into the healthcare management systems, and that will be a social move so that other social benefits can be accrued from the management of the digital healthcare systems. That actually is the mobile-based healthcare system, wherein each individuals can be connected by downloading the app from the systems. That system allows individuals to talk to the doctors at any point of time. They can get engaged through a system called Ask a Doctor, engaged in chat with their chosen doctors in the platform. They can be issued, they can get a prescription, e-prescription from the systems, and appointment with the specialist doctors can be booked across the country. Video consultation with the specialist can be arranged, that, and doorstep pathology and sample collection can be organized. And personal health records can be maintained and stored in the systems. maintaining the entire systems in the cloud. So protected by password, shareable from anywhere and at any point of time. And that actually allows repeated text, generating repeated prescription, generating repeated records and other things. And so each individual will be empowered with their own health records. They are educated, they will be educated, so they will be able to manage their own health, a database in the dashboard, and this will be a breakthrough in the management of well-organized digital healthcare systems. And preventive care, primary healthcare, or family healthcare can be introduced through these systems. And this will allow the insurance coverage so that the system allows you to get connected with the healthcare financing systems. This brings benefit to the citizens in a bigger scale because digital health is records-based care and cure, empowerment with health knowledge and history, and access to health facility. These three things are fundamental in the family care management. So each individual will be empowered with their own health records, and that will allow them to know their health first and to manage their health, and then that will allow them accessibility to the healthcare facilities whenever they really need the support from the physicians or the healthcare systems. And that will actually allow individuals to monitor their wellness. Personal health record actually is a reinforcement of individual so that he or she can understand how well or how well they are and what needs to be done to keep themselves well. And then promoting good health is always a good thing for individuals to pursue, and this is available over phone. So it is in the healthcare at your fingertips. Digital connectivity with the care providers will allow you 24/7 doctor's consultancy with chatting with them. So that will allow you preventive notification, that will help you to get discount at hospitals and diagnostic centers, and that facilitates to reduce your repetitive tests and other things. So this healthcare finance will be minimized, and life and health insurance coverage is possible. Paperless insurance claims and submission and claim settlement is possible, and 27 for customer service will allow you to remain connected with the healthcare systems all through your life. And that benefits this should be the healthcare mission for any nation, and Bangladesh government is trying to pursue on board this healthcare mission, digital health with a clear dashboard, health database for preventive healthcare management for the mass people, multi-layer, cluster-based and comprehensive dashboard for the health database for all citizens, digital prelude to consolidated national health database, access to latest health status of all groups, opportunity for timely medical intervention, and feature of the smartphone. This is actually possible with any kind of phone, and this mobile-based or phone-based telehealth systems will be a new generation healthcare management systems across the board. Health insurance coverage, which is very minimum in this country, less than 1% penetration of the insurance, health insurance, because of people's apathy to the insurance. People do believe that insurance is for the people after the death, but insurance can be a source of financing the healthcare systems in their lifetime. It is not being considered. It is not being considered. And surprisingly, I was actually listening to Dr. Gogunas Krishnamurthy's presentation on financial literacy. He told about everything excepting the cost of the healthcare management. So this is one area which needs to be incorporated in the healthcare literacy also, also, so that it actually combats healthcare expenditure, and it actually reduces the surprise for individuals in any given situation in terms of maintaining their wellness and well-being, which is an essential part of the lifestyle management of any citizens in any country. So this is for now. I'm sure you'll have questions on this, and I'm open to answer to your questions. Thank you all.
Thank you very much, Prof. Harun, for the insightful speech. In fact, you have really navigated very well from problem identification, from global perspective, and then macroeconomic directly to your contribution in how you could tackle this issue in a microeconomic way. That's very, I say, kudos to you. Well done, Prof. Okay, Prof. Before we have been receiving several questions of more, I would say, very controversial, yet very interesting questions. So before that, let's start with the first preliminary first. So being an accountant, your profession, and being have been highest achiever in accountants, being a professor, how did your transformation from accountant into healthcare? So how does
this is a lifetime experience. So in our individual life, personal life, actually, all of us are really, really negligent about the maintenance of our own health. We never thought of that the God has given us a body, a health, and we always thought that it will be maintained by the God Almighty. But in the real life synergy, it has been found that it is very important to know about your own health, number one, and it is your responsibility to maintain it. Maintain, I mean, you need to be conscious about your management of your own health. And first thing in our life, we always have been very negligent about our maintaining the health. And that is where the fragmented healthcare system is responsible for this. Because when we feel sick, what do? First thing we do is wait, let's see. Next, I became doctor for myself. I go to the pharmacy. We always, in every family I know, in our country at least, everybody maintains some medicine at home, self-prescribed medicine. So people by nature uses self-prescribed medicine, which is very dangerous. Number three, when we take medicine and then we do not consider the consequences of having self-medication. So it leads to more complications. When complications are developing, then we go to the pharmacy to buy medicine by ourselves. So on the third day, even third stage also, we do not get the opportunity to consult the doctors, because the going to the doctors is a frightening thing. Whenever you go to the doctors, we anticipate that more unfortunate things are coming to me. Every individuals are facing these things, so they are really, really, people do not like to go to the doctors. I'm not sure, well, how do you face it? But when you see a patient, the patient is not happy about it. It's not a happy go about venture for a person to go to the doctor. So they always feel. But when you are educated about your own health, then whenever you will be meeting a doctor, it should be a happy moment that I am reconfirming my wellness. But instead of doing that, I am going to the doctor with a sad mood. The doctor will be actually giving me some treatment, and I will be subject to sufferings for that. So all these things actually has compelled me to learn more about how can I myself and grow out of these things. That is why actually I gradually penetrated into the management of individual healthcare systems. And now with the technology in hand, advancement of the technology, I see the opportunity of individuals to get educated about their own health, to know about their own health, to take care of their own health. So when I'm taking the responsibility of all my properties, as you mentioned, money, set, everything, why not I take the responsibility of my own health? But unfortunately, people by and large has given it to the physicians And physicians take the responsibility heavily because it brings money to physicians. It brings money to them. And in between, I'm sure you will not like these things, but it is the reality. And unfortunately, the government has a responsibility. In many countries in South Asia, government has failed tremendously, has failed to take care of the health of their own citizens. So in our country in particular, if you happen to be any government hospitals, you will see that the government hospital is overcrowded. There is no space for the patients to even stand there. Beds full, side beds full, corridor full. So this is the scenario where we live in. But there are opportunities now to overcome this synergy. To first, on the first day, you can contact your physician or the systems so that you get help from the healthcare providers. And if you can address the illness or sickness on the first day, you save your money, you save your health, you save your energy, you raise your working life, your money is saved, national health is maintained. So that actually brought me to be interested in the healthcare financing systems, and healthcare financing's most commendable opportunity is waiting for us to get into the digital healthcare systems and digital healthcare financing.
On note to that, Prof, you've answered very well, Prof. And Prof has stated that government spending has been reduced. 26% is only the government spending on the health financing expenditure, and out of own pocket is has been raised to 68% the current year. So, do you think, in your opinion, in professional capacity as a policy maker, what would be in the macroeconomic point of view, what would be the best financing model?
No, for the government actually, how the government is providing fund and where the money is going. Government is providing fund for creating infrastructure. So government is providing infrastructure for the healthcare system. They are providing hospitals. They are providing money for the organization for the development of the hospital systems, for the education, medical education, for other things. But within the framework of the government's total financing systems, healthcare management is not in the top of the agenda. So feeding the people is at the top of the agenda. The housing is the top of the agenda. And education is the top of the agenda. So healthcare management, as I mentioned, is not at the priority level of individuals in countries like ours, and nor it is the priority of the government. So that is at the bottom of the agenda.
I'm sorry, Prof. In contrary, Prof, as we know, this medical tourism, for example, in Malaysian medical tourism, last year itself, 800,000 has been medical tourism. We have been entry into Malaysia. So that leads to revenue of almost USD $1.2 billion in private scheme. So that means it's also one of the Bangladeshi has been a lot of Bangladeshis has been coming to Malaysia for medical tourism. So in note to that, so what's your take on that? So I mean, there's been always been said as it's underdeveloped, it's country, but however the spending is very good. So how do you reckon that, Prof?
Well, this is an issue that this is business and social welfare is absolutely different. Is absolutely different. If you look at the developed countries, say if you talk about USA, that is 100% covered by the expenditure is 100%. The medical expenditure, health expenditure is 100% covered by the government. So they take the responsibility of the citizen for the 100% care. So you don't have the opportunity to grow as private practitioner. You don't have the opportunity to grow as private medical colleges or private medical hospitals. So you don't have the citizens do not get the opportunity to call a doctor at home or to get an appointment in the private chambers at any point of time. So that is the difference between the approach of the healthcare management. So when the medical tourism sort of things are coming up, so this is for the rich, as I mentioned. those who can afford it. But unfortunately, it doesn't solve the problem. Only a insignificant percentage of the people can afford to go for the best of the best treatment. But they could avoid this best of the best treatment or medical tourism if they would take the opportunity in the first places to go to the government hospital in their own country. If they would get the opportunity to get treated well, so the question of accepting medical tourism would not arise. So medical tourism is a business proposition for the rich people, for the rich countries, for the rich countries in the commercial world. So health is actually, to be honest, health should not be an initiative of the commercial venture. But when it comes down to that, it is going beyond that. It is for the rich, and it is for the management of the business, not for the welfare and wellness. It will not bring wellness and well-being as is pronounced in the Sustainable Development Goals.
Okay, following to that question, Prof, I do have questions from audience. What are the literacy rate of Bangladesh? Number one. What are the literacy rate of Bangladesh? Number one. Number two, what are the types of social health insurance would you advocate based on your experience? And what are the level of contribution by the individual, which is sustainable? And what are the safety net for the indigent?
Well, the literacy rate is almost now 70% here, we call it now. But there is controversy over this number. But when it comes down to insurance penetration or social insurance penetration, it is less than 1%. So that is the whole crux of the problem. The insurance for the healthcare is not yet promoted as vigorously as it is needed. So there are opportunities for the in Bangladesh. There are around 200 insurance companies. All of them are interested in life insurance, not in health insurance.
Right. I'm going for the final question here. So, in your opinion, in your best opinion, so would you think does any other, for example, NGOs and could be a help for any probably from World Federations, organizations of World Health Organization would be a great help for Bangladesh in terms of improvement in health financing? Would that a great help or?
I think at this point in time, none of the philanthropic institutions are effectively helping the government. The government budget is financed by the World Bank. This is World Bank and ADB. So that is a loan money to the government. So none of the international organizations or any other country is actually helping government citizenry to establish a good healthcare systems. So it has to be structured around its own community. It has to be, as I mentioned, the community-based healthcare system has been, clinics has been established, 13,000 community clinics has been established with World Bank financing on loan, but the coverage is not that good because clinic has been established, infrastructure are not being built upon it, promotion has not been actually being made to attract people to take service from the community clinics. So it has to structure around their own world so that people get educated about their own health. People are interested in taking services at the very first instance of their sickness or wellness. And that is where actually the whole issue can be improved as a nation, that digital healthcare systems can be a breakthrough, can bring a breakthrough in the entire systems. And we are trying to provide this platform as a national platform so that people get interested in this, and success definitely is waiting for them.
Thank you very much, Prof. Your innovative design is very noble. Hope you will succeed in the program. And before moving on to the next speaker, would you like to give any closing remark, Prof?
Well, the issue is this. This is the digital penetration of the healthcare system is not specific, no country specific. It is a generic one. It is organic. So it can be a model for the entire world that people can be connected with the entire healthcare system across the world through their healthcare, through the digital healthcare systems, because the fundamentals of the health, vitals of the health is their own health information, which is called EHR, EMR, whatever you name you give. This is the fundamental asset of one individual. So that individual, if can be connected into the ocean of the world healthcare systems, that brings benefit to individuals, that enhances the quality of the healthcare systems across the world. So in the digital world, the individuals of any race, any country, they should have the opportunity to talk to each other, to get engaged in consultation, in the treatment, in the advice, whatever, and across the world. So the promotion of digital healthcare system should be the agenda of the sustainable development goals, particularly in terms of achieving wellness and well-being of individual at the individual level, at the family level, at the national level, at the global level. Thank you.
Thank you very much, Prof. Harun. That was well. I hope many are inspired with your sharing. We had a huge knowledge from your side, from Bangladesh perspective. I'm sure it could be helpful in our next Malaysia's context as well. Wish you all the best and good luck to you, Prof.
And thank you very much, Dr. Gugunashan, and thank you very much for inviting me. And I wish you best of luck with the Malaysian Medical Association. Thank you.
Thank you very much, Prof. All right. Our next topic is by Dr. Muhammad Anis bin Abdul Wahab, Deputy Director of National Health Financing Section, Planning Division, Ministry of Health, Malaysia, and former head of Department of Quality Assurance, Protect Health Corporation, Sania Berhad, to present about health financing in Malaysia. Dr. Muhammad Anis is a medical doctor with a degree from the International Medical University Malaysia, IMU. He has received an international scholarship to undergo clinical attachment in organ donation and transplantation with the Donor Life organization in Australia. He has also received a Chevening scholarship to do his master's in health policy, planning and financing from both the London School of Hygiene and Tropical Medicine, as well as the London School of Economics and Political Science from UK. He was also part of the research management team collaborating with the Harvard School of Public Health on the Malaysia Health System research from 2014 to 2018. He was also part of the founding team for the not-for-profit company, Protect Health Corporation, which is owned by KKM. Currently, he is the Deputy Director at the Planning Division and heads the National Health Financing Section. Now I shall pass the floor to Dr. Anis for his speech.
Thank you, Guga. It's a pleasure to be here today. This is my first ever MMA Asked and Answered series. Let me just try. You can all hear me well, right?
Loud and clear, Dr. Anis.
Okay, right, so that's my presentation. I suppose I should start off with a couple of disclaimers. One, I am not here on behalf of the Ministry of Health. I'm totally doing this on a personal basis. So any views and opinions are that of my own. It does not represent the Ministry of Health. That's one. Second, I am not a pakar perubatan kesihatan awam. I know that when Guga approached me to do this, he had asked for me to perhaps go into how budgets are channeled to states and PKDs. I've never worked in a PKD before, but I thought that would be more suitable if we were to, if a PPKA were to present that in a different series. My approach would be very much looking at it at the more higher level, at the HQ ministry, national level policy making. And third, while I know that I've been asked to do this pro bono, but it is by no means a presentation which is not based on a decade, almost a decade of working in the Ministry of, at the top level, a wealth of experience talking to practitioners from other countries and looking at their best practices. And of course, over the years, understanding the concerns of those on the ground and trying to see what can be done to make, so to speak, everyone happy. All right. Okay, so let's start this presentation. Just check my time. So I thought I would just slightly tweak the topic to more on understanding health financing policies in Malaysia. Well, excuse me, I think I'm hearing echoes from my own.
All right. So, okay. Thank you. Right. So what I will do today is more on introduction to health financing. I know that some of you may find this quite basic, but I'm trying to understand the audience. There may be those who are not familiar with health financing. There may be those who are expert already, but let's start off with the basics. Then we go into understanding Malaysia's health financing system. And then we look at how health financing policies in Malaysia are developed. And I thought I was given more time to give a presentation, but I thought I would more welcome discussions and questions, anything that can be brought up for us to discuss in more detail. And of course, we'll end up with the conclusions. So in the introduction to health financing, and I'm sure most of you would have seen something like this or something familiar, where the WHO has this health system performance framework where we have, when we think about a health system, we know that there are four main functions: stewardship, making sure that the country or the overall health is moving towards what we wanted. There's creating resources in terms of manpower, in terms of infrastructure. There needs to be investment, and there's of course training when you're talking about manpower. Service delivery, how services in terms of healthcare are provided, and of course financing. Now at least the first two up down to the third is something that people always think that Ministry of Health is responsible for. But I would like to take off that I'm taking off my Ministry of Health hat, and to say that all this is part of the health system, be it public, be it private. So there needs to be a function of stewardship, creating resources, service delivery. And now it goes into financing. And I'll have a further slide on what financing is all about in terms of health systems. But more importantly is to move away from just looking at the inputs, but looking at what are we trying to achieve with a health system. And that's the three goals that are on the right there. So where we want an improved population health, we want our population to be healthy, we want to have some level of responsiveness, patient satisfaction. I think we are moving from the old days where we don't even care how our patients feel, or so to speak, if in the business sense, how our clients feel. So there needs to be a level of responsiveness to fulfill patient satisfaction. And of course, there's financial protection, making sure that no one becomes poor because of it. So, and of course, those of you who would be sharp enough would know that the first two, responsiveness and health status, as well as financial protection, make up the universal health coverage, where you know everybody gets the healthcare that they need and nobody becomes poor of it. So more importantly, what I'm trying to say is the health system must achieve these three ultimate outcomes. And of course, we also put in our country, because we find that important, is that should be equity, that all these outcomes should not be only only certain level of people or certain class of people get to feel the best of it. It should be distributed equally. Okay, so the functions of health financing. And I know, again, am I being too basic here? But you would be surprised that when I talk about health financing, there are people out there, whether in the government or even at the international arena, they only see health financing as the first function, which is raising or generating revenue. And of course, that is how the health system generates and collects revenue. How is health finance, who pays, and more importantly, who is covered. Going back to what I mentioned earlier about equity, we should be talking about, when it comes to health care, it should not be linked to the ability to pay, meaning that only those who can pay for healthcare should get the best of healthcare. It should not be linked at all. It should be in terms of the need. So that's an important aspect. Pooling, where we combine financial resources from multiple sources to share the financial risk of paying for healthcare. And this is how people are protected. I'll have a slide on it later on. How do we ensure equity? Again, I suppose I will not get tired when we're talking at the ministerial level, talking about equity, because that's something I strongly believe is important, and how negotiating can be better. I'll talk about this third point later on and try to relate it to pooling. And third function is purchasing, mechanisms to pay providers for healthcare services. So this looks into what is provided in terms of healthcare, how can we achieve efficiency, and how is quality attained. So these are the three functions which, whenever we talk about health finance, should be in the back of our mind. So it's not just about raising revenue. Remember that there's also an element of pooling, there's also an element of purchasing. Okay. Oops, I can't. Okay. All right. Okay. Allow me to talk about pillars of fiscal space. Now, I should mention that don't bother too much. Don't be worried about too much about my slides. It's just more for my assistant in terms of guidance for sharing this presentation. But most of my slides are adapted from easily available resources. So I got this from the World Bank. Now, the pillars of fiscal space, there are 5 categories. And when we talk about fiscal space of health, it's the availability of budgetary room to increase government spending for health without jeopardizing broader macroeconomic and fiscal stability. Basically, when we talk about where we can get that revenue, we need to have this in mind, especially when it comes to what the government should provide in terms of providing that budget. So fiscal space potentially can be generated from 5 categories of sources. First is conducive macroeconomic conditions. If I were to simplify it, it's basically making sure that we have a big pie. The budget, if we were to say the budget was a pie, having a big pie. So if in periods of good economic growth, we would have a bigger pie. Second would be reprioritization of health within the government budget. So then once you talk about the pie, you want to talk about the slice of the pie. So there will be times when the slice of the pie is big enough for health. Sometimes it may be less, because when we cut a big slice of the pie, it's going to affect other people's slices. So we are fortunate in Malaysia that so far, especially in the Ministry of Health, we have received about 10% of the budget for health. But we are second to education. And we'll talk about whether that's enough or not later on. But certainly, there is that reprioritization of health. And of course, if you were to ask me, I would ask for a bigger slice of the pie. But again, bear in mind that it would affect other people's pie allocation. Third is this increase in health sector specific resources. And what this means is, especially when you talk about, recently we heard in the budget that 50% of the excise duty for vape products will be given to health. In other countries, you would have taxes on tobacco or on sugar sweetened beverages or alcohol. So that's also an increase in health sector specific resources. Now, before I go into the fourth one, I probably should say, because I'm afraid I might forget later on. So of course, all those taxes that I mentioned, it used to be known as sin taxes. Now it's then it moved on to pro-health taxes, and now it's just called health taxes. Now, the important thing to remember is, for most of us, we support such taxes because we want that reduction in the unhealthy behavior. Yes, it's a bonus that we get some revenue from it, but it should always be, because evidence shows that when we provide adequate taxation on these unhealthy behaviors, it does reduces that unhealthy behavior. So that's certainly something that we want. And it becomes a paradoxical situation if we depend on the taxes for our budget, because we want to reduce that that unhealthy behavior, and that would ultimately reduce the revenue. So it should never be about the revenue, but it should always be about the unhealthy behavior. And of course, it has to be at the right amount. Then the fourth one is increase in efficiency of existing government health outlays. And fifth is the health sector specific grants and foreign aid. We heard from Prof. Harun just now that for Bangladesh, they receive a budget from a loan from the World Bank. So in Malaysia, we have less of that pillar of fiscal space in terms of increasing our fiscal space. But if you notice that the first, if you're looking at 1 to 4, only the fourth one is within the control of the Ministry of Health, where the ministry can improve the efficiency of how it uses its allocation. Number 1, 2, and 3 is actually beyond health ministry. So I always find it quite amusing that when people talk about, oh, how can we increase the funding for health in the ministry or in the public sector, that they leave it to the Ministry of Health, when the reality is, in most situations, it's only number 4 that the ministry has direct control over. The reality is 1, 2, and 3 is very much in the realm of the Ministry of Finance as well as the government. So bear that in mind when we talk about how we can increase the revenue on health to the public sector. And why? So why am I so gung-ho about talking about increasing public spending? You may have heard that one of the levels, especially in the health white paper, that we want to increase up to 5% of GDP in terms of public spending. So overall, currently, last 2021 numbers revealed that Malaysia is spending about 5.1% of GDP on health, where 2.93% is in the public sector. And the idea is to increase it to 5% of GDP. Why 5% of GDP? Because we see that when we look at upper middle income countries to higher income countries, their levels are up more than 4% up to 7% of GDP, the percentage of public funding for health. So if we were to say, yes, of course, if you look at the lowest level, it would be 4%, but we want to think further on and we want to reach the level of high income countries, we should be at the level which is on par as other countries. Of course, it's not easy. Well, so why, again, strengthen public expenditures? When we talk about universal health coverage, UHC, going back to my first slide, why we need a strong health system. We need it so that UHC can be achieved. And without public funding, UHC cannot be achieved. Government funding helps reduces poverty and inequity. And again, it's that thinking of equity again. Again, you will not hear me tire of talking about ensuring that the poor, the vulnerable are covered. Out-of-pocket financing is efficient and equitable. I'll talk that a little later on in another slide. With public funding, there is more incentive to invest in evidence-based and cost-effective services. I already mentioned a bit on health taxes, which curb unhealthy behavior while generating revenue. And of course, there's also this argument, well, don't bother about public spending, let's talk about social health insurance. Yeah, that can be considered, but remember, even social health insurance requires government funds, because who's going to support the poor? You can't expect them to cough up their own money to cover for their healthcare. Again, going back to that issue of equity. So even if social health insurance was to be introduced, government funds would still be needed. And again, just again to strengthen my point, why there are problems with out-of-pocket spending, meaning that when someone wants to get healthcare, they pay on the spot. That's where direct payments by individuals from income or savings to healthcare providers at the time of service use. This is inefficient and equitable use of resources. You may be fortunate if you have enough savings, but if you don't have those savings, it would be quite difficult for you to pay if you were suddenly charged with a high fees on healthcare. People are less likely to pay out of pocket for preventive care. Again, when we all know that preventive care is much better than curative care. So, but people won't even bother for it when they have to pay out of pocket. There's an inability to pay, becomes a barrier to accessing needed care. Prof. Harun also touch on this. If you have hardly any income or any out of pocket, you start wondering whether you should even be getting care. The cost of falling ill is fully borne by the household. There's no pooling of funds as a population. That will be touched upon later on in my pooling slides. And of course, it exposes household to catastrophic health expenditures. And I hope I'm not patronizing all of you, but remember there are when we talk about catastrophic spending, there are two types. There's catastrophic spending as well as impoverished spending. Catastrophic spending, we are fortunate in Malaysia that we are quite low. It's less than 2%, and that's the level when how much of the proportion of household income is used for health. So if a huge proportion, it's about 10 to 25% of the household income is used for healthcare, that's already catastrophic, because then you're left with less income to use for your other basic necessities. And the other term is impoverished health expenditure, where whatever proportion you use, it can be smaller, it can be bigger, but it causes that household to fall into poverty. And in Malaysia, our national poverty level is about 2,200 ringgit per month per household. So if any healthcare causes you to your income to fall to a poverty level, that's already impoverished health spending. So just bear in mind whenever those terms are being used. Okay, so now here's that point about objectives of pooling. Contributions are independent of health risk. So without pooling, everyone would have to pay for their own healthcare when they are sick. Without pooling, payments would be driven entirely by how sick a person is and what treatment they required. Redistribution, with pooling, resources are redistributed so that service use can be driven by health needs, not ability to pay. Basically, if you have a pool, if everybody contributes to this pool, then the sick can be taken care of, cost subsidized. The cost of the care of the sick can be cost subsidized by those who are healthy because they're not using healthcare. The poor can be cost subsidized by the rich, and the productive will cross subsidize the non-productive. Non-productive, you can say in a way, children, they're not in a productive period of life. The elderly who are retired are also not in a period of non-productivity. So if I were to relate this to Malaysia as an example, where, for example, as a Muslim, I'm proud to pay zakat, but whether we realize it or not, zakat is very much fragmented. The pooling is based on states, where Selangor has a zakat fund, Sabah has a zakat fund, Negeri Sembilan has a zakat fund. What happens is that then you have less of the benefits of pooling. For example, in 2021, about 1 billion ringgit from the zakat fund in Selangor is used for healthcare. Now that's fine for Selangorians, because in reality, more Selangorians pay zakat. There are more of them who are have enough income to have that zakat deduction. But how about somewhere in Sabah, where there's less zakat, but there's less people who pay zakat, and there's less people who have enough income to pay zakat? If they were to depend entirely on that zakat fund, it would not be enough. That's why it would be good to pool. So that's why I also, I'm going into somewhat a controversial comment here. I would be careful whenever a state asks for autonomy. Yes, autonomy in general is fine, but be careful of what we're asking for, because as we see in zakat, each state has their autonomy, but it doesn't mean that each state gets equal benefit. So that should be something that we should bear in mind. And shifting from, so going to that third function where we talk about purchasing, we should shift from passive to strategic purchasing. What is deemed a passive purchaser? Well, a passive purchaser will allocate funds to health facilities irrespective of the quality of the services or the cost of delivering them. But as a strategic purchaser, makes choices based on the need for different health services. So I remember when in the UK, there was but I forgot the name of the district. So that district had more elderly people in the population. So there was less allocation for assisted reproductive therapy, because you don't expect that population of elderly people to suddenly think, oh, I'm going to have a baby then. So then you start allocating your limited resources better. Of course, we want a strategic purchaser will look at the availability of effective medical interventions. We want a relative cost effectiveness of different interventions. I still remember a friend of mine in a certain country, which I won't mention. He was just complaining of a backache, and he's still young. But the first thing they did was do an MRI. So even though it was not warranted, so that's not cost effective. But if you pay providers a certain way, you get that as a consequence. So that's where a strategic purchaser will be able to purchase cost-effective services. How people access these services, example, availability only in urban areas, that should also be taken into account, not only for the patients, but also for the providers. You could argue that providers in certain areas, urban areas, have to pay higher rent, or the cost of operating is higher. So the rate of payment should be different. So that should be taken into account. The quality and efficiency of services delivered by providers is the ultimate aim. We want to ensure that we're not just purchasing services, but we want to purchase services of quality, so that patients would go somewhere in the knowledge that they will get the best treatment which is available at that place. And of course, this is an argument that I have started to make whenever I'm involved in defense budget. So whenever we request a budget, again, according to what we request, we try to relate it to returns of investment, because that's the reality. I remember when I first started work and I was trying to defend on organ donation transplant, it wasn't enough to just talk about life saved. That's the reality, because the Ministry of Finance would want to see how much, by saving those lives, how much does it bring to the economy. And it's important to have that in our mind, that when we talk about impact of investing in health, we talk about healthier populations and improve human capital. We strengthen labor markets. It generates significant national revenue, impact positively on other sectors, and a strong investment in health can lessen sudden shocks and long-term impacts on health status and the economy, as what we had to endure during the pandemic. So in terms of Malaysia's health financing system, and this is probably not something new to most of you, but let's just go through it. So what are the challenges in Malaysia? We have a dichotomous two-tiered healthcare system. We have an established public system, as well as a thriving private healthcare system. But whether we like it or not, there are rising healthcare costs. And the reality is the rate of medical inflation is much higher than general inflation. So whenever we request more funding for health, it's because the reality is that medical inflation is going at a much faster rate. There's high levels of out-of-pocket spending. As I mentioned earlier on, Malaysia unfortunately still suffers about 30% of our total health expenditure is due to from out-of-pocket spending. So that's still quite high. Again, I'm going back to an earlier point, we have insufficient public funding for health, which is evident in some of our facilities in terms of our burden of our public facilities. I think it relates to what Prof. Harun had mentioned earlier, although not to the extent that Prof. Harun, but nonetheless, we are seeing it, our public fund sector being strained. There are health system inefficiencies, both allocative and technical. That's something the health economists among you would know. The reality is we have so many resources in both the public and private sector, and we need to use that optimally so that it benefits everyone. And of course, there's a suboptimal private health insurance model. I apologize to any of you who have a stake in private health insurance, but this will be a point that I will emphasize more later on. But the reality is our private health insurance model is suboptimal. And of course, this is a diagram that some of you may have seen. And again, is to show the dichotomy of our health system and how it interacts. Perhaps I wouldn't go too much into this, but there is a mismatch in terms of our resources. So if you look on the left of that red line, that is more on the public sector, and on the right is more on the private sector. And if you look at the hospital bed days, 75% of the public sector is seeing more patients in the hospital. In terms of outpatient visits, it's 64%. But when you look at the numbers, obviously, there, especially when you look at our outpatient GP clinics, there are more GP clinics compared to KK. So there's a mismatch. How can we better optimize that problem and that issue? And of course, I need to say, this is more on to look at how is Malaysia doing in terms of going back to that earlier graph I showed you, whether we achieving the outcomes that we want. So based on the reports, apparently Malaysia is doing well in terms of UHC. The HAQ index in 2016 shows that we have a 68 number, but of course it's still a long way to go compared to countries like Norway and Australia. And likewise, while we can argue that we have reached UHC, but it's still we could do much better when you look at the countries above us. So you could argue, maybe, are we really doing that well with regards to UHC? And just to look at, again, whether we're doing really well, is that while we have important achievements in terms of facing challenges, where we have improved maternal child mortality, but no discernible improvements in the last 10 years, we're actually seeing a plateauing of our improvement. Of course, we're going to face aging population, high levels of health risk, chronic illnesses, and we have an excess of avoidable mortality. And we want a system which is equitable and considerable satisfaction. The reality is, I've talked to some people in the government where they say, what's wrong with just if we're seeing high spending in the private sector? And there's nothing particularly wrong with that, but we need to see who is spending that. Is it at the expense of the vulnerable group? Because they might not be able to purchase services in the private sector at the price that is being mentioned. So we need to find a system that allows them to also obtain those services, be it in the public or private sector. Oh, this is just to again compare our levels. So I had to take 2019 numbers. I know that I mentioned earlier 5.1% total, but if you look at current health expenditure, which is used to compare other countries, we are at about 4.4 in 2021, but in 2019 we are 3.84%, but only 2% is actually government spending. Now, I'm using this because to show when we compare to the average in upper middle income countries, we are way low. In terms of the current health expenditure is almost half, but government spending is not enough, where we are upper middle income country is 3.84%. Now, I'm saying this because there are certain parties who say that, oh no, we're not doing so bad. When you look at the first row, current health expenditure, we're not so different from, say, Thailand. But when you look closely, they spend much more on government spending. There's more investment, where it's at 2.78% of GDP compared to our 2%. And there is a much less out-of-pocket spending at 8.5%, the lowest row. When we in 2019, we had 36.1%. So that shows that there's less risk of going into catastrophic or impoverished spending. So you shouldn't just look at the numbers of current health expenditure, but also look at the general government health expenditure as well as out of pocket. And some may argue, we're not that different from Singapore, where although it's still higher than us at 4.42%, but again, they are, in terms of government spending, they're still spending more than us, 2.28%. And of course, their out of pocket is much less. So there are still areas of our investment into health that needs to be improved, even when we compare to other countries. Okay, all right. So now I'm going to mention that my gripe with the private health insurance, and it stems from inherent market failures because of the nature of private health insurance. There's adverse selection where those who purchase health insurance will probably be those who know that they're going to need it. So that's the tendency for only sicker patients to purchase insurance, and this only drives up the premiums. There's risk selection where the insurer themselves, the company, there's the incentive to engage in what is called cream skimming of health. So they only try to pick healthier members because they don't want to be paying out the claims. So then this excludes those who really need it. So for example, excluding the age and people in poor health. There's the problem of moral hazard. Some call it the buffet syndrome, because now you're no longer paying for your own healthcare. You have that tendency to just purchase want anything that you can. And that's always a problem. Even currently now in the health sector, it was just yesterday that I was talking in a conference that we all had that experience where either our relatives or patients had a box full of unused medication, which they just didn't take, and they don't realize how much that cost the government. When you total it out, it's millions of ringgit. But because they didn't have to pay for it, they just leave it just like that. Now, provider induced demand. I know some of us are providers here, but there's also that tendency for providers to supply for unnecessary health services because of course they're saying that they're doing it for the patient, but because neither one is paying for it, then there's more tendency for that to happen. Again, I go back to my friend who backache suddenly gets an MRI. Market concentration, and this is due to high capital requirements and sophisticated technical knowledge needed to manage insurance. The reality in Malaysia that there's an oligopoly of, actually there's only two, three health insurers that dominate the market share for health insurance, and that's not something good. So in Malaysia, this has resulted in private health insurance only bought by those who can afford it. You hardly hear of those who have lower income having health insurance, which only perpetuates the problems if they need healthcare. Luckily, they have the public sector to fall on, but that's where the public sector becomes overcrowded. You have lack of risk pooling. Again, only when there's adverse selection, or even only those who can afford it, there's no cross subsidy of the poor subsidized by the rich and the sick subsidized by the poor subsidized by the rich. There's non-comprehensive benefit package. We all know about the pre-existing illnesses that are excluded, or certain other illnesses that are not covered by the health insurance. That's a problem because we want to make sure that healthcare is comprehensive enough to cover health needs when a patient needs it. So that leads to lack of financial risk protection. The reality, there's also caps or annual limits. So once you reach that cap, you suddenly have to be, if you were in a private hospital, you would have to be transferred to a public hospital. And again, that causes even more patients at risk of losing income and so on. All right, so now going to, I didn't realize I was a bit slow in this. So, okay, now, health financing policies in Malaysia. Now, when we talk about developing health financing policies, there are three questions that we should at least ask ourselves. What objectives are health financing policy reforms trying to achieve? And it goes back to the bigger arcing objectives would be the three UHC objectives that I mentioned earlier. But of course, don't just come up with policy for the sake of policy, but trying to really understand the problem and how we can solve it by having that policy reform. What is the proposed content or instrument of health financing policy? The good thing about health financing, there can be specific tools or instruments that can be used, and that's something which we need to synchronize with the objectives that we want to achieve. What constraints does a country face in its ability to achieve these objectives or to implement? The reality is, as a health finance policymaker, first, of course, we want to look at technical feasibility. But the reality is, in any government, and we heard it from even Bangladesh, there's also financial feasibility. We want to do certain things, but if we're not getting the funding, well, let's say we want to do nationwide IT integration. If you don't have the financing for it, it's going to be difficult. So financial feasibility also needs to be taken into account. That's a constraint. And of course, the reality is in our country that, and any other country, I suppose, political feasibility, that can also play a role in affecting what policies we want to implement. And of course, we have guiding principles on how financing. We emphasize predominant reliance on public funding sources. Public funding for health should be about 4 to 5% of GDP. Malaysia is currently 2.93%, as I mentioned. Out of pocket should be less than 20%, but Malaysia is currently 31.5%. So how can we do, what instruments can we introduce so that targets can be achieved? And we should move towards more strategic purchasing of health services. We should purchase value, be more efficient in how we purchase. With whatever small allocation we have, we should be more efficient in how we use it. And we need to introduce these, what are called provider payments, and link them to performance and to population health needs. Let's move away from the thinking, it's enough just to give our patients medication, but let's try to achieve together with the provider and the patient. Instead of just how many anti-diabetic drugs we give, why not the aim should be better control of the diabetes. And of course, it's not easy, I admit, but that's where both provider and patient has to work together. And that's what we really want. It's not just about, I'm giving you this much medication. We want better control of whatever illness that we have. And just to share some numbers that we have managed to crunch out, when investing in health can contribute to the economy. I have used this whenever certain discussions with the Ministry of Finance, for example. If we can do this properly in terms of investing properly in health, the expected population health improvement will provide strong economic growth, about 0.3% per annum GDP growth rate. It sounds small, but reality is with increased overall workforce productivity, that's about up to 2 billion per annum. Increased workforce, because you now have an increased workforce because you have reduced premature deaths. You have reduced disability in the workforce. You have increased participation from the elderly, disabled. And once the caregivers of the elderly and disabled no longer need to spend all their time doing so, then they also can be involved in the workforce. And of course, increase in highly skilled healthcare workers as well. And altogether, that's a total contribution of 7 to 8 billion per year. So again, I'm trying to show to the powers that be, it is worth investing in health in terms of economy. Of course, it should be about saying that the fact that someone can live a life is value enough. And these are some of the health financing initiatives in the 12 Malaysia plan. I won't go through it, I suppose, in the interest of time, but certainly you can look up where it's related. If you look at number 2, increased funding for health, that's certainly something that we want to do. And number 1 is a blueprint for Malaysia healthcare system reform, which is what we are currently doing with the introduction of the health white paper. So I suppose I can leave this time for discussion. I would certainly want everyone to think, has Malaysia actually achieved UHC? Because if we're not, that shows that we are not investing enough in health, because our health system isn't robust enough to achieve the 3 outcomes that we were talking about earlier on. And of course, that said, is the current model of health financing sustainable? Yes, first, I'm asking for more, but even if we had more, would it be sustainable? And what health financing policies tools should Malaysia consider? I think I'm open to questions now.
Thank you, Dr. Anis. That was a very thoughtful and critical thinking slides, I would think. So I do have a number of questions here. Let me start with the first one. So as we know that from the budget, last year, 2022, 32.4 billion were allocated for health. And then it was steadily increased to 11.8% in 2023 to 36.3 billion ringgit. So yeah, we do have an increment in the health spendings, but yet we're still getting the insufficient public health spending. So why there's a contrary? Check out the findings there. What's your take from there?
Okay, so let me just if I. The reality is, again, in 2021, it was public spending went up to 2.93%. Again, if you want to be really sufficient at the level which is on par of the upper middle income countries, you're talking about 4%. That's about 1.07% of GDP increase. So the how many was it? About 3 billion ringgit is hardly 1% of GDP. So the reality is it's not enough. But that said, we have to also take into account the government situation of the country. Remember, going back to, oh sorry, where's my slides again? The fiscal space. I'm not so gung-ho to the fact that I don't recognize that the government. We also need to look at the reality is now the first pillar, we have a much smaller pie. Yes, we are getting at least reprioritization of help within the government budget, but reality is the pie is much smaller now. But and again, I agree, reality is still not enough, because we were already working on, in the public sector, we were already working on a level which has been low under investment for so many years. So just that increase wouldn't be enough to get us at the level that we want. I don't know whether that answers the question.
Sure. So following to that, so there's a question from the crowd audience is, we continue to practice passive purchasing in Malaysia. That is an extreme purchasing. How will we transition to strategic purchasing when our national health system does not yet have an established patient classification system such as case mix?
Okay.
And
so I think,
can we figure out from this?
Okay, so I think it has to be step by step as well. Certainly, I know that our colleagues in the Ministry of Health at the Medical Development Division are looking at DRG case mix introduction in the public facility. We should at least start at the public sector if we want to introduce that, to determine how budgets are allocated to our public hospitals. That's something that's looked into. Again, strategic purchasing, if you look at the policy levels, which I haven't talked about, strategic purchasing is about who are we purchasing it for and what are we purchasing. Second is from whom are we purchasing. The third is how we purchase. This question is focusing on, i.e. the provider payment mechanisms. And fourth is what is the performance? This is in terms of governance. So going back to perhaps the what we are purchasing. This is where, if you remember my slide, I talked about looking at more cost-effective interventions. And this is where HTA, if we can strengthen our HTA, we can at least focus more on interventions which are more cost-effective if we have enough evidence. So that's already part of strategic purchasing as well. Second, looking at from whom are we purchasing from. And this is where we have introduced where I was introduced as part of Protect. It was meant to look at quality. It's not to say that our private providers are not of quality, but the reality is we need to reach a certain level of quality. For example, our private labs, which was part of the PECA B40 program, how do we make sure that they are of enough quality? So there's an accreditation process using the MS 15189 pathology standards. And of course, currently the private labs are not obliged to do it. But under the PECA program, we insist that they do.
So that's ensuring that a certain level of standards are achieved by paying only for accredited services. For example, of course, this can be expanded. So then you go into how we pay. So then you can introduce the capitation, mixture of fee for service. When these are things that we are currently, the ministry, again, I'm not representing the ministry right now, but I know that the Ministry of Health is trying to look into and trying to explore in terms of improving the efficiency of the purchasing. So yeah, it's baby steps. I have to admit, but it's a step in the right direction.
All right. Okay, next question will be, in terms of poverty, when we say in economic point of view, less than 2,200, right? So how about in
I can't
terms
hear
of,
you, Duga.
can you hear me?
Did I silence myself? I can't hear. Hello?
Hi, Dr. Anis, can you hear me now?
Sorry,
Can you hear me now?
No?
Can you hear me now, Dr. Anis?
Oh, yes, sorry. Yeah, I can now.
So the questions I was addressing about was, in terms of economic point of view, when we say poverty is less than 2,200 ringgit. So in terms of medical, so what is the quantifiable measures? What's the level right now we are in? In terms of poverty.
I'm trying to understand. Maybe I don't understand the question enough.
So where states we are right now? So as we said, the states we are doing good and so on. Is there any poverty?
All right. So I suppose what I can say is based on 2019 HIES data, which is from DOSM, our catastrophic spending in general is less than 2%. However, if we were to look into more detail, the M40 is doing okay, about less than 1% of in terms of catastrophic spending. But if you look at B40, it's 5.5%. Are at risk of are already facing catastrophic spending. Now, of course, when you compare it to what Bangladesh was facing, Prof. Harun was saying 16%. Of course, it's much better, but it worries. We should be worried that if we were not to protect our healthcare system enough, that people who are vulnerable, like the B40, again, there's that huge difference. About 0.3% for the M40, but 5.5% are facing catastrophic spending. Yes, we can pat ourselves on the back because it's still low, but it's still a danger, it's still at risk. And if we don't strengthen our health system, there's always that risk that that number can increase. And again, we're already seeing cracks. I suppose going back to the performance of our country, the reality, we talk about health status. Yes, the reality is that our health status isn't improving that much because the number of NCDs and especially the number of undiagnosed NCDs. Now, when it comes to responsiveness, that satisfaction, we all know that in the public sector, there's dissatisfaction because overcrowding, long waiting times, and in the private sector, it's more about how much it costs. But we need to be aware of this. And when I'm talking about again, I'm going back to that person, that government person who was questioning why should we worry about the private sector because the poor can always go to the public sector. The reality, based on NHMS data, 25% to 29% of the bottom 20, bottom 40 in terms of income, the bottom two of the first two quintiles, lower quintiles in terms of income, actually use private sector services. And why would that be? Orang kata tak ada duit, but we have to accept the reality is that the poor might not be in a position where they can go to they might be, if they go and wait for so long in a public facility that they lose the time off because they are paid per hour. So every 1 hour waiting at our clinics, they lose 1 hour of income, which could be vital for them. They might be only able to go to clinic at outside of office hours when our public clinics are closed. So they are dependent on the private. So we need to find a way where we can still help them use our public facility, both public and private facilities, without them having to spend out of pocket. And that's where the public funding comes in. I don't know. I'm sure I may have missed that question. And forgive me if I didn't quite understand what the question was.
No worries, Dr. Nix, no problem. Well, leading to that, okay, as we know that, as for example, a government employee, they spend only RM1, for example, at the registration counter, but they're able to get a treatment, they're able to do an X-ray, they're able to do a lab test, and if required, referral to hospital, and for example, MRI, CT scans, so on. And how about, let's say, for a private candidate, they're still able to enjoy these benefits, but very minimal charges applied. That's good enough. But since the expenditures are more than the government funding, so as like I mean, expenses, whatever the expenses are incurred from these medical expenses are more. So government has taken several measures. For example, one of them is introducing public and private partnership. For example, those clinicians who work in government sectors, they can do in private sector as well, in the hospital, government hospital facilities with a very reasonable charges as well. So what's your take of this project? Is this project has been taken off very well? And is there any challenges? Or what's your take on that?
Is this the take on allowing our local public clinicians to work in the private, or is it more on?
That means it's like government doctors who are able to provide the services in a private wing in the government facility, very minimal charges. So hence this would create a revenue for the government.
Oh, okay. Okay. I'm trying to see how that works. Creating revenue for the government. I don't think that should be the aim, though. Trying to see the right angle to do this. Okay, first, let's establish that we all want to optimize our resources, whether it's in the public and private sector. So that's a given one. So how do we work on that? I suppose we can reduce the cost that it takes, that operating costs in the private sector by having our public clinicians work in the private facilities. Yeah, I think that to some extent that can work. But I would be wary that it's not necessarily much cheaper just by doing that, because then our clinicians would need to have insurance coverage and so on, working in a private facility. I suppose it's about looking at negotiating reasonable costs between both the provider and the payer, to the extent that okay, if you, for the PECA B40 fund, because we're providing B40, I suppose it provides a market to the private sector who wants it, who may not be having those clients coming to the clinics, so that it might not be at the price that they get from having a rich patient coming in, but certainly because there's numbers coming in, that's another business consideration for the private sector to consider, which would probably help in the negotiation with the public payer.
Right. So leading to that, so so I mean, what is there any other measures taken from the government sectors to improve their revenue? I think I did mention about just now full paying base thing. So is there any other measures taken to increase the revenue, despite with the minimal spending, which could benefit the public?
So there's only a few options that we have. First, we need to increase general revenue, general taxation. Are we in a position where we can increase taxes? That's something, again, a question that while we can say, yeah, we should, but then it's a Ministry of Finance to answer. Reality is, in terms of taxation in our country, only 13% of GDP is from our taxation revenue. So that shows how much. Well, you could argue, or maybe we can increase it further to increase our coffers. But then again, I wouldn't have the figures of who can we tax. Of course, you can talk more on wealth taxes as opposed to more income tax, but that's a possibility. Then you go on to, so the taxation could be either general taxation, or the other form of taxation is through payroll taxes, i.e. What we are doing with KWSP, but on per capita, but to some extent, let's earmark it for healthcare. That's what is done in the national health insurance and social health insurance. National health insurance being more of where the government also contributes on behalf of the vulnerable group. Other than that, you're moving towards a less efficient way of increasing revenue. Some people talk about Singapore, the medical savings account. Now, the problem with medical savings account, if you recall my presentation, it has a lack of pooling, because you're saving only based on your ability to save. You're not pooling that that fund together. So those who are poor would have less savings. Those who are rich would have much higher. That's the problem with medical. It benefits those with higher income, but not necessarily those with lower incomes. But even the Singaporean system also starts off with a basis of public subsidies before they go into the medical savings account, as well as health insurance, be it public or private health insurance.
Thank you, Dr. Anis. Okay. So would you like to give a closing remark before we end this session, Anis?
All right. Are you sure that I've answered all the? Oh, because time is limit.
Yes.
All right. So I suppose my message has been something that my professor, Prof. Atun, had mentioned. I'm definitely advocating to the government that we should have more money, i.e. more spending, because it also brings more money to the government in terms of the economy. So more money, more value for money. Even if we don't get more money, let's use whatever money we have better, be more efficient, buying value. So that's more money, more value for money, more value for many. Let's make sure that whatever we do, we don't leave out the vulnerable group people in our society. So that's where the equity comes. So more money, more value for money, and more value for many. So don't leave out certain sections of the society. So I suppose that's my remark, if it makes any sense to any of you.
Dr. Anis, I think that's remarkable. Actually, you've given us a huge, a different perspective of health financing. What is the back of the curtain, in fact. So I'm sure that's a statement was saying that they were, at the moment, there wasn't any plans in building new hospitals, but ongoing spend on the ongoing projects, for example, 2 hospitals in JB, also the improve the services in the 146 hospitals in Malaysia, and also increase number of medical specialists and consultants in government facilities. And also, if I'm not mistaken, also the relieving the strain in the 40 hospitals, over which has 80% of a bed occupancy rate. So,
sorry, I know that I said at last remarks. That goes to the point where when we talk about building hospitals, so public-private partnerships is meant so that we don't need to build hospitals, because then we can work with existing facilities that are available even in the private sector. But we shouldn't forget that certain areas are not served by the private sector, rural areas. So then it becomes the responsibility of the government to still build or provide services in those areas. So there will be times when we optimize resources which are available, but there will be times when it might seem counterintuitive, but we still need to build more or provide more because those areas are not served. Again, goes back to that argument of equity. It might not be efficient. I know that there are schools in the rural areas that only serve a handful of students. Yes, it's not efficient in terms of economic sense, but in terms of equity, again, going back to my last point, more value for many. Over.
Thank you very much, Dr. Anis, for the critical thinking presentations and very good interactive engagement on Q&A sessions. So with that, we have reached to the end of MME Public Health Ask and Answer series, 2 years 2023, organized by MME Public Health Society. On behalf of MME Public Health Society, I, Guga, would like to thank the speakers and also all our esteemed guests for your participation today. Once again, I would like to thank our secretary who has supported our webinar. Just a kind reminder, all doctors who participated for the 2 hours, 2.5 hours webinar shall be eligible for 2 CPD points. Kindly note that you're required to scan a QR code using MMM mobile app, and QR code for the CPD points will be shared on screen for now for your viewing. Thank you once again. Have a great night. See you in the next series with much more exciting topics. Take care. Have a pleasant night.